Into session 2, which is surviving sudden death in Jamaica. Interestingly, we've heard from 2 of our speakers today about sudden death in Jamaica and its repercussions and what we can do about it. So I want to bring to the stage Dr. Felix Sogade, MD, FACC, FHRS. He's a past board chair for the Association of Black Cardiologists. He is a preeminent electrophysiologist. He does arrhythmia and irregular rhythms of the heart. He is the Chief Executive Officer of the Georgia Arrhythmia Consultants and Research Institute. And he just has a wealth of knowledge to share with us. And would you help me welcome Dr. Sogade to the stage? I would also like to welcome to the stage Dr. Corey Jagon, who is one of our own graduates and has gone through the medical system right here in Jamaica. He is currently a medical officer at the Heart Institute of the Caribbean and has been tightening his skills and really preparing to go to seek additional training before coming back home to serve us. So I would like to welcome Dr. Jaggon to this stage. Okay. Gentlemen, over to you.
Morning. I'm just going to be presenting 3 cases that we had at HIC recently that were near-death cases that required us to resuscitate these patients. Let's get into it. So, at the first slide. All right, so the first case, a 44-year-old male that came to us, no chronic illnesses. He had chest pain the night before he presented to us, which became more severe on the morning of presentation, to the point he couldn't bear it anymore. When he walked into HIC, he was in severe pain, was diaphoretic, and our clinical staff immediately realized that something was wrong with this guy, seriously wrong with this guy, and immediately carried him over to our emergency room, where we started putting leads on him to do his ECG and taking a brief history. Before we could do any of that, unfortunately, he became unconscious, was pulseless, and so we immediately started CPR. On the monitor at the time, we noticed rhythm in keeping with ventricular tachycardia, and he required 8 rounds of CPR. So we shocked him 7 times, gave amiodarone and epinephrine, intubated him during the resuscitation, and he did regain spontaneous circulation after those 8 rounds. And we transferred him to our CCU with vasopressor and ventilator support with a plan to do his angiogram. So unfortunately, we weren't able to get an ECG done before he arrested, but immediately after he regained spontaneous circulation, this is what his EKG showed. So here we can see he's in sinus rhythm here, he's tachycardic, and he has these wide QRS complexes. He also has left axis deviation. The QRS morphology looks like it's in keeping with a right bundle branch block, and that combined with the left axis deviation also led us to think that he also had a left anterior fascicular block as well, which our very smart ECG machine also thought. He also went into a brief period of atrial fibrillation, or what we thought was atrial fibrillation at the time, with this irregular rhythm, no P wave seen, and but with similar QRS morphology at the time. He eventually went back into sinus rhythm. We were able to extubate him, started speaking again, walking around, and again, similar to the first ECG with that right bundle branch morphology there. And these are just his subsequent ECGs that we did, which have that very similar morphology to that initial ECG. His labs post-arrest, so his ABG here you can see is very acidotic. His lactate was elevated, which is expected post-cardiac arrest. So he had a lactic acidosis. But unfortunately, this patient opted to be transferred to another institution, so we weren't able to continue his care and do his angiogram after that point. I think he remained well for about 2 weeks before we unfortunately learned that he suddenly passed away following that. So Dr. Sogade, if you'd like to.
Hello. Yeah, I think that was a very good presentation of a patient who came in with unstable arrhythmia and rapidly deteriorated. Can you go back to the first EKG that you got here?
Yeah.
I think when you look at this EKG, most people in the audience will say clearly that's a wide complex tachycardia, and the differential we always allow when we see a wide complex tachycardia rhythm is that is it ventricular tachycardia or is it due to a supraventricular arrhythmia with aberrancy? One of the cues is that there are several criteria we use, but the most popular is the Brugada criteria for whether you have a left bundle pattern EKG or a right bundle pattern EKG. In a right bundle pattern wide QRS tachycardia, the most important consideration you should have is that is there presence of a QS pattern in V5, V6. In this particular patient, it appears that maybe there is a QS pattern in V5, V6, but when you look at in lead V6, there is a small R wave in that lead, and that would make me hesitate to truly call this truly VT. And then the other pattern is a tall left rabbit here pattern we described in lead V1. And this patient has a tall right rabbit here. And so that differential becomes a little bit of a concern whether this is truly VT or is a supraventricular arrhythmia with aberrancy. Then the third consideration is the presence of a R wave, dominant R wave pattern in lead AVR. But when you have a dominant R wave pattern in lead AVR, it's most likely ventricular tachycardia. But this patient has a kind of a RS pattern in AVR. So, and when you have a dominant R wave in lead AVR, you should have a negative complex in lead 1 and AVF to really call it VT. So my impression is that this patient, when unfortunately, you are not able to get an EKG before you're arrested, yeah, but the resultant EKG most likely reveal a supraventricular arrhythmia with aberrancy. I don't know if there is any other comment from the audience to, address that. Or maybe, I know there are a lot of electrophysiologists in the room that may want to chime in. Okay? Excellent. We can go on.
Okay. Yeah. Next case.
All right, thank you.
Next case. Yeah. All right, so moving along. So second case that we had recently, so this was a 67-year-old man, known hypertension, and he also had a hypertensive heart disease. So he also had a history of palpitations, and on previous 24-hour Holter monitor, we had seen runs of supraventricular tachycardia. Also had an angiogram done around 2014 when he initially started having those complaints. That was normal. But on this presentation, he came in complaining of sudden onset again of severe chest pain and diaphoresis. Soon after arrival again, he collapsed, but he remained conscious, was diaphoretic, had altered consciousness, and he was, we put him on the monitor and his heart rate was 220, and he was hypotensive, as you can see there. So we did manage to get an ECG on him before doing anything, and this is what it showed. So there's a wide complex tachycardia again, and again there was a decision to be made at that time as to whether we thought this was a ventricular tachycardia or SVT with aberrancy. Regardless of which one it was at the time, because of his he was hypotensive with altered consciousness, we had to intervene immediately. And so he underwent synchronized cardioversion. And following that, we got the subsequent rhythms here. So here again, you can see that he's in a wide complex rhythm that was irregular with no clear P waves there. Again, looks like a right bundle branch block morphology. So we thought he was in atrial fibrillation at this time. He eventually went back into sinus rhythm, so you can see regular rhythm with P waves, but still had the same wide QRS morphology from both the initial ECG going into now. Also have some echo images from him here. So he had some, from his previous diagnosis of hypertensive heart disease, some thickening of his left ventricle there. And if we move on, also had some wall motion abnormalities there. So if you can look at the lateral wall there, it's just not pumping as well as the rest of it. And again here, you can see the lateral and inferior walls are just not looking as active as the rest of the left ventricle. So subsequent angiogram that we did showed that he had a very, very distal LAD thrombus, so there's a filling defect there, as well as some other lesions. So there was a 50% lesion in the first diagonal and a 30% lesion in the proximal circumflex. We didn't perform any intervention at that time. Started him on medical management, and he remains well to this day. No recurrent similar episodes, and we continue to follow him up. Repeat angiogram is scheduled to see how that lesion has progressed over time, and we'll look forward to seeing that. So these are some of his angiogram images as well. So you can see the that defect there in the LAD, distal LAD. And just another view of it. Right.
I think from the electrophysiology perspective, I know some of the interventional colleagues may want to comment about the coronary anatomy, but at least just briefly looking at the echocardiogram, you can see there are some wall motion abnormalities on the echo, at least in the probably anterolateral aspect of the EKG, of the echo. And then when you go back to the EKG, when it came into sinus rhythm, it can render some understanding about the presenting arrhythmia. That definitely, when you look at this patient, he has S-wave in lead V6 and very poor wave progression, almost with a typical left bundle pattern. And the first EKG of the white complex tachycardia is very different from the EKG of sinus rhythm. Like I mentioned previously, any pattern of a QS pattern in lead V5, V6, most likely will point you to VT. And in this particular patient, he has a very dominant R wave in lead AVR. And you will say it's most likely ventricular tachycardia if you have a dominant R wave in lead AVR. Especially, it has to be accompanied with negative forces in AVF or V1, or lead 1. And so in this particular patient, most likely presented to you, this EKG is consistent with ventricular tachycardia. Right. Though, when you look at the EKG in sinus rhythm, you can almost, it's a little bit confusing, but what this tells us is that the scar mediating this VT is most likely in the anterolateral to apical region of the left ventricle. Yeah.
And moving along to our most interesting case, I think, that we had. So this guy was a 47-year-old male, only known to have asthma. So he was having shortness of breath and palpitations for 2 weeks before he presented to us. And this is what he presented with on his initial ECG. So looks regular with that kind of sawtooth pattern almost that you can see between the QRS complexes. So at this point we thought he was in atrial flutter with 2-to-1 conduction. One thing we also noticed at the time was that at the start of that QRS complex there was almost a delta wave there. And so there was some concern for pre-excitation syndrome at that time. Our initial plans were that we're going to perform his TEE, looking for left atrial thrombus and cardiovert him if it was normal. But our initial transthoracic echo, along with the findings you can see there, they most significantly saw that he had a apical thrombus in his left ventricle. So at that point, we put our plans for cardioversion on hold, and after much discussion, decided that we would indeed try to rate control him with beta blockers. The subsequent ECGs after admission, that delta wave didn't look so as obvious as it did in that initial ECG. So just some still images here of the initial echoes that we did, and you can see on the apex of the left ventricle there, what we thought was the thrombus at the time. You can see it a little more obviously in this image here. So his ejection fraction was also about 25-30% at the time. So we also did his angiogram to rule out ischemic heart disease, which was normal. So at that point, we thought his heart failure may be related to the tachycardia that he'd had for over 2 weeks now. With the rate control, we had some success and got his heart rate down to about 80, fluctuated between 80 up to 120 beats per minute. And we also started him on anticoagulation since he had that thrombus in the left ventricle. He also developed a little infection during his admission that we managed with antibiotics successfully. So just showing you the angiogram images here. And there was nothing no clinically significant stenosis that we had found. So that's left side and right side. All right, so the interesting thing happened 10 days into his admission. He started complaining of left-sided abdominal pain, vomiting, and diarrhea. So when we went to talk to him to try and take a history from him, we noticed on the monitor that he went into what looked like monophasic ventricular tachycardia. Again, was hypotensive with a very high heart rate. That kind of forced us to perform cardioversion on him at that time, despite the previous echo findings that we had. And we were able to get him back to sinus rhythm. We also did CT abdomen that day. We suspected that the thrombus may have gone to a vessel there causing mesenteric ischemia, which was normal, and those complaints resolved by later that day. All his labs after that were normal, and to this day we're not sure where that thrombus, if it really was there, went. So this was his ECG after we cardioverted him. So he just has some T-wave inversion in V5, V4, V3. And also, even though he doesn't have that delta wave looking thing there, PR interval still seems a bit shorter than it should be. And these are just his echo images that we are not the best quality, but post cardioverting him to just show you that we don't see that thrombus there anymore. There's a little bit of something there in the apex still that might represent some organization of the thrombus, but we're not sure. It's definitely not as clear as it was when he came in. So we started him on amiodarone to maintain sinus rhythm, and to this day he's well, has not gone back into atrial flutter or any other rhythm. And we're considering ICD placement at this time if his cardiac function doesn't recover with time.
Yeah, you have some very interesting cases. Yeah, very challenging. The first EKG during the atrial flutter.
Let me get back to that really quick. There we go.
Definitely that EKG is kind of concerning, but I can't see it AVF very clearly whether this patient truly has a pattern of pre-excitation or is it a pattern due to pseudo-pre-excitation. And pseudo-pre-excitation you can see sometimes in the setting of infiltrative diseases or hypertrophic cardiomyopathy. And but it's possible that during the atrial flutter, there was more rapid conduction through the accessory pathway, giving you that pattern. But with the EKG, it's kind of very difficult to localize where the accessory pathway is.
Yeah.
And so that always will make you concerned that is it pseudo pre-excitation or is it truly pre-excitation? But the short PR interval is definitely worrisome that this guy has some abnormal conduction. But the more concerning thing is that why did he develop an apical thrombus? On the subsequent echo, it doesn't look like it's completely akinetic in the apex.
Right.
And then, so you have to start wondering what are the conditions that predisposes to development of intracardiac thrombi, as a mechanism. Some of the infiltrative cardiomyopathies, there used to be a lot of talk of eosinophilic infiltrative cardiomyopathy, and it's a possibility, and then the issue of non-compaction. I don't see any left ventricular non-compaction under EKG under echo to suggest that, but this guy, and there is no coronary artery disease to explain that, so you always have to worry. Is there some other type of infiltrative process going on with this gentleman? Yeah.
Right. Okay.
That's my discussion.
All right, thank you, Dr. Sogade. So yeah, those are the three cases that I brought to show you guys today. I'm just going to hand over to Dr. Sogade. He's going to go through some stuff as well.
All right. Thank you, Corey. I think that's a future electrophysiologist for Jamaica. We're looking forward to working with you in the future. And at this point, I must commend Daniel and Ernest for putting such a wonderful team together, and the rest of the team at HIC. I really commend you for this wonderful meeting. And I really enjoyed myself last year, so I'm back here again. Today, I'm just going to give a kind of a general overview about, what are some of the current concepts and how we need to perhaps rethink the question of sudden cardiac arrest. As you all know, sudden cardiac arrest is a situation is a common final part for many mechanisms of dying, but most of the terminology refers to a situation where there is cardiac standstill as a result of a predisposing arrhythmia mechanism. And the illustration I show here is from some recent discussion and how perhaps we should really look at this subject. So I don't know whether there is a pointer. I don't have a pointer, but I will just, when you look at the portion down there where the patient is being resuscitated, that's the time zero, when we tend to see a lot of patients that will come in with sudden cardiac arrest. At that point zero, unfortunately, that is the first encounter, as we heard from some of the presentation and the speakers earlier today. Unfortunately, that's the first contact many people will have with the medical system, that they come in an emergent situation in cardiac arrest or being resuscitated, or they are observed to have collapsed at home. And when you suffer cardiac arrest in the United States, I don't have statistics for Jamaica, the estimate is always staying around 330,000 a year, and the numbers may vary. But when you suffer sudden cardiac arrest, most of it will subsequently result in sudden cardiac death. That means about 90% of the people who suffer from sudden cardiac arrest are going to die. And so at that point zero, the chance that you have to really be able to help somebody is limited. And so when I now want to walk back this discussion from the point of sudden cardiac arrest and say, how can we walk a step back at that point, and then we'll walk forward a little bit about what happens after sudden cardiac arrest. If we look at that point zero, and the patient comes in, or they collapse at home, and you activate the emergency system, the most opportunity you have to be able to help somebody relates to, do I have 2 minutes left? All right. All right, so the most opportunity you have relates to the use of an AED to be able to emergently resuscitate somebody. And the quicker an AED is applied, the better it is. But the problem we have with AED use is that, one, there's a lot of place and time mismatch because even when you look at the studies done in several urban centers in the United States, half of the AEDs are in offices where the public or the community may not have access to it. So there is a question of place and time mismatch. And then when you also look at the number of people who have sudden cardiac arrest, initially only about 1 in 7 had bystander CPR. And why is that? Is it that the people just don't want to help, or is it that they don't know what to do? And when you look at the way you solve that problem is that you have to really train more people, because in most populations, only about 2.5% of the population are trained in doing bystander CPR and AED use. And even just before traveling here, in our community, we started a program of donating AEDs to the community and training high school students, trying to push an initiative in our state that before anyone graduates high school, they should know how to do CPR and use an AED. And I just consulted on a 19-year-old who was just doing a warm-up game yesterday during basketball and collapsed. Luckily, his teammates were just trained by us about sometime last year. They started CPR, they knew where the AED was, and this gentleman was just not even intubated. He's awake and sitting in the ICU currently, awaiting additional workup. So at that time zero, we have an opportunity to be able to help somebody. And then, but at that time zero, what we know about sudden cardiac arrest is that most people who have sudden cardiac arrest have had an interaction with the medical system. They have seen a doctor in the weeks or months before, or they had some symptoms that they ignore. But some of these symptoms are so non-specific. Did they feel dizzy? Did they have nausea and vomiting? Did they have, some chest pain that went away? And people do not know that, of what to do about those kind of symptoms. But we know from the minutes to weeks, days preceding, people have some type of symptoms. So then we may have an opportunity that how do we understand and predict what will happen now to someone? I think the future of improving the knowledge base in this field, that's something that will really help us is there are a lot of monitors that are now inserted in people. In the US, we use a lot of loop recorders to monitor people with syncope or atrial fibrillation. There are people who have pacemakers that may not be able to deliver a shock. And then there are also a lot of wearables with the Apple Watch, Fitbit, and all these other devices. Is it possible that with this aggregation of data, we're just at the FHRS meeting last year, we were visiting Apple Corporation, and they have this tactigraph of data. Anyone that wears that Apple Watch in Jamaica, they have a tactigraph of what the average heart rate is in this town, and then they can break it down. Is it possible for us to go back and look at those EKGs and those rhythm problems? Yeah, okay. Is it possible to use that data if you go back and say, can we now do a complex computer analysis, machine-based learning, to predict and analyze what are the events that truly happened to people before they had a cardiac arrest? And then in a theoretical model, we can look at that data from those devices to now go back and say, what is the heart rhythm pattern that predates the ultimate event? And then you can now also go back, even if we go further out, can we prevent some of these events if, for example, these devices have an ability? We all have, a lot of people are using these assist devices in their homes now, like an Alexa or some other type of device. Is it possible for the activation from the analysis of these devices, when they analyze the rhythm and they predict that there is a dangerous event about to happen to you, using Bluetooth connection, tell your Alexa to call 911 to come to you, or activate emergency response on your behalf? Those are some of the potential future of where some of the research, and then you have to go through all the legal ramifications of those kind of concepts. And so those are, some of the thought processes, relating to sudden cardiac arrest. In this particular situation, we look at the general population of people who have a high risk for sudden cardiac arrest. We can look at people who have structural heart disease or people who have had prior sudden cardiac arrest represent the highest risk. But we also know that people who have had a family history of sudden cardiac arrest, any fourth-degree relative history of sudden cardiac arrest, double your own risk as an individual. And as we all sit in this room, it's estimated that at least 1 in 7 people will suffer from a sudden cardiac arrest of some kind, And so it's important to now be able to say, how can we not just talk about population risk? Is it possible to get to individual risk? And when you start getting down to individual risk, what I have is a lot of these axes and Venn diagrams. If you take somebody with a reduced ejection fraction or cardiac comorbidities, they represent the highest risk. The overlapping factors can now enable us to predict an individual risk. If I can predict an individual risk for somebody, then I may be able to say, well, your individual risk is low or your individual risk is high. You may be able to at least seek treatment on an earlier basis. And from the data that at least collected over the last several decades, we also know that the pattern of dying is beginning to shift from ventricular tachycardia and ventricular fibrillation. We're now seeing more and more people die from progressive heart failure, pulseless electrical activity, and asystole is becoming a dominant pattern of dying. And some of these mechanisms do not generally respond to current AED use and other things. So there are other mechanisms that we may have to bring into play about how do you resuscitate people who come in with PEA and asystole. The use of mechanical assisted CPR is a consideration, and there is a concept about medium voltage stimulation of the thoracic muscle to help in people with PEA and pulseless electrical activity. But by and large, these graphs here just show you the decreasing incidence of cardiac arrest due to VT-VF, and asystole has remained more or less constant. And by and large, the best therapy we still have for preventing sudden cardiac arrest is an ICD. But with ICD use, it has its limitations. In somebody who has ventricular arrhythmia, ICD is very effective in reducing cardiac arrest. Somebody who has a functional heart failure class 2, they may represent the most benefit. But as heart failure advances, you see this U-shaped curve here. As heart failure advances and the number of risk factors increases, the benefit of ICD starts diminishing. As people get into class 4 heart failure, they have multiple other comorbidities, then the benefit of ICD use is diminished, but there is still some mismatch about who should truly get an ICD, and that's where I think the concept of individualized risk, assessing scar burden, and some other people, and people who may not fit the current predictive model out of our current guidelines may be useful. Thank you. Sorry, I see the red light.
You don't mind if I sit? It's quite devastating when we have cardiac arrest situations in children engaged in sports. Mm-hmm. And of course, it's more devastation than adults who have problems that may cause cardiac arrest. Mm-hmm. So we have a foundation, Jamaica Foundation for Community Development and Health, mm-hmm. and we are doing clinics for children involved in sports in schools in Jamaica. Mm-hmm. It's a program that has just been started. We have done approximately 1,000 students, and we select those that we do ECGs on, and then the ECGs are sent to, of course, Heart Institute of the Caribbean. Mm-hmm. They are read, And then from those groups that are red, we select out the students that may be at risk, depending on what the ECG shows. Of course, it's difficult to do there are many schools in which this is required, and we are trying to get public support for this. And what we do is we are training a bystander program in some of the schools. We have just started that program, and again, HIC is very much involved in that program.
Oh, wow. That's a very good program. I think the question of screening, especially in young population, is always a challenge about the resource and the cost. But I think using the questionnaire to screen for at-risk individual and then sub-selecting those who need an EKG is a very, very good program. But by and large, I think the best opportunity that we have seen is we started this program about probably now about 12 years ago. I went to a 5K run to about breast cancer awareness. And I said, well, there is nobody doing an awareness campaign for sudden cardiac arrest at that time, because many of them are dead, so you don't really have a chance to have survivors come and speak. And survivors of cardiac arrest, they don't like talking about it in some way. So I think, community-based program to raise awareness about CPR and AED use, and making sure these AEDs are located in places where people can get to it is also very important. Yeah. All right. Thank you.